Good evening, everyone, and welcome to today's wonderful session. Sorry I got very late today, but I don't feel at least few questions we should be able to discuss before we go to sleep. So with that preamble, let's make the great beginning. But otherwise, every day we try to do the 100 questions full-scale grant test revision by the end of the day. So, doctor, yeah, let's make the start. What is not seen in herpes gestationalis? Yeah, let's make the start. What is not seen in herpes gestationalis? Yeah, let's make the start. So, though the word says herpes gestationalis, it is nothing to do with HSV. There are tense bullae, peri-umbilical lesions, deposition of the C3, they're all true. But it is not associated with the herpes virus. It is typically seen in the second or third trimester. It is an autoimmune blistering skin disease, is what you need to remember. So basically, herpes gestationalis is often considered to be a type 2 hypersensitivity reaction, is what you need to remember. Now, a fair skin patient with atopic eczema who has mental retardation. So you should know all these inborn errors of metabolism. How do they present? Is one of the favorite question of the examiner. So phenylketonuria, scarring versus non-scarring alopecia. This is a frequently asked question in the entrance exam, doctor. Be very sure about it. So you should remember, alopecia areata is a recurrent non-scarring type of hair loss. So if you look at, just give me 1 second. Just one moment, doctor. Yes, so all causes of scarring and non-scarring alopecia, you need to make the list. Now, what are the most characteristic nail defect that you see in psoriasis is a favorite question of the examiner. So this is called oil drop sign, doctor. Oil drop sign, which is considered to be the most characteristic nail defect of psoriasis. Geometric pitting of the nails, where do you see? In alopecia areata, multiple small superficial pits which are regularly distributed in a geometric pattern along the longitudinal and transverse lines is a classical feature. Whereas irregular pitting keratolysis is seen in psoriasis. Then what radiation type that emanates from the disintegrating radioactive material? It is alpha decay is the classical radioactive decay. Today, the internet is very slow here. Yes. Okay. I hope the broadcast is coming quite interrupted. Just bear with me. Scottish Terrier sign. Where do you see Scottish Terrier sign? It is the oblique view. So the oblique view will make you to identify the spondylolysis. So whenever there is a pars interarticularis between one vertebra and other vertebra is broken, it looks like a broken neck of a Scottish dog, which is the classical feature which you see in case of spondylolysis is what I want to underscore to all of you. What is the carbon dioxide laser wavelength? It is around 10,600 nanometers. Minimal right pleural effusion, if you want to look for, then right lateral decubitus view, even a very small amount of the fluid, as small as good to see almost 8 online classmates. So as small as 10 to 25 ml can be seen on this right lateral decubitus view. You are able to see the layer of the fluid. Now, in TB, what are the classical radiological signs? Is the favorite question. String sign because of the cicatrization, a pulled up cecum and a gooseneck sign. So this is basically called the pulled up cecum. Pulled up cecum, loss of normal iliocecal angle, and the terminal ileum appears like the gooseneck, which is the classical feature. Now, medullary breast cancer. Typically, lymphocytic infiltrate usually manifests as a palpable node mass. And if you look at the prognosis, a medullary histology statistically has got a better prognosis is what I want to underscore to all of you. Once more, doctor, one of the favorite questions you need to remember is breast carcinoma. Exam, tomorrow's NEET PG is not for 200 questions. It is only for 199 questions because one question invariably comes from the breast carcinoma. A 42-year-old underwent lumpectomy, axillary dissection, estrogen receptor negative infiltrating ductal carcinoma, which is moderately differentiated. 1 to 19 lymph nodes were found to be positive. 1 of 19 lymph nodes is found to be positive. So what is your treatment? Always a node positive breast carcinoma. Post-operatively, multi-drug chemotherapy and radiation therapy should be followed. That is considered to be the management of choice. So a lot of randomized studies have been conducted. Is there any benefit of adjuvant chemotherapy in the premenopausal women who are node positive? If at least 1 to 3 positive nodes are there, then adjuvant chemotherapy is logically useful. That's the point you need to remember. Then another important thing, should we use tamoxifen or not? It all depends on the ER status. If the cancer is estrogen receptor positive, then tamoxifen has a role. But if it is ER negative, then tamoxifen doesn't have a role. That's what I want to underscore to all of you. So once more, this is one important area in breast cancer that you need to remember. Node positive, node negative. Premenopausal, postmenopausal. Do you want to use tamoxifen or not? So these are all the important issues. Now, for primary maintenance immunosuppressive agent, it is the tacrolimus. Tacrolimus and if you compare tacrolimus with others, there are fewer episodes of refractory rejection. If you take mycophenolate mofetil, azathioprine, sirolimus, they're not as potent as the tacrolimus is what I want to underscore to all of you. So, with regard to the interleukins, interleukin 8 is a neutrophil chemotactic factor. Interleukin 3 is a hematopoietic growth factor. IL-4, IL-6, IL-10 They are known to have inhibitory functions. Interleukin-6 inhibits the tumor necrosis factor. Interleukin-10 inhibits the monocyte macrophage function. So these are all the important things about interleukins. Definitely एक question आएगा, ये तो completely बत्ती मारने वाला item है, but you need to be 100% sure about that. Now, ECF expansion. For the extracellular fluid expansion, what is the stimulus? Hemorrhage leading to hypovolemia. Increased capillary permeability after major surgery. Any negative interstitial fluid hydrostatic pressure. They're all considered to be the stimuli for the expansion of the ECF is what I want to underscore to all of you. Now, post-operative fluid management. There is an insensible loss of 600 ml per day, and it can increase to 1500 ml per day. And all the GI fluids which are lost should be replaced millimeter to millimeter. So these are some of the basic principles of management of the replacement of the fluids post-operatively, one of the important area. Then once more, doctor, hernia is a sure short topic in the tomorrow's NEET PG. Direct, indirect, inguinal hernia, femoral hernia, lumbar hernia, umbilical hernia, epigastric hernia, all these funda. Without a question on hernia, there is no exam paper. So be very sure about it. Now, what are the components of the Hazel-Banks triangle? The medial border of the rectus sheath, Cooper ligament, and inguinal ligament. So you should know very well what constitutes the Hazel-Banks triangle. The inferior epigastric vessels, as what you can see, the inferior epigastric vessels, they are the superolateral border. Superolateral border. This is outside, this is medial aspect. Because this is the central line, right? The medial border of the triangle is formed by the rectus sheath. The medial border is formed by the rectus sheath. Then the inguinal ligament serous, as the inferior border is what I want to underscore to all of you. Now, after the groin repair, groin hernia repair, recurrence is one major challenge. So, what are the modern interventions that decrease the chance of recurrence in the case of the hernia repair? Now we are using pre-peritoneal space for hernia repair. Then tension-free is a very important concept. We are using prosthetic material. They're all responsible for decreasing the recurrence rate. Whereas the Bassini's repair, and there are modifications of Bassini repair. We have discussed in a great detail in our surgery. Once more, I advise you, if you have done this question wrong, please go back to the Incus app, 2000 HD videos. In that, in the surgery videos, hernia is the topic very, very elaborately discussed. If you have done this question wrong, please go back to the 2000 HD videos on the Incus app and do the revision. Schulditis repair, McAvey's repair, they are the modifications of the Bassini, but they all create tension at the suture line. That's the reason, in fact, they will increase the recurrence rates. That's the point you need to appreciate. A patient in a surgical ICU developed nutritional deficiencies because of the dysphagia. and anorexia. Ejection fraction is just 25%. There is a diffuse muscle soreness. So what is the most likely deficiency leading to all these sequelae? Typically, it is the selenium deficiency. Selenium deficiency produces Keshan's cardiomyopathy, myalgias, loss of pigmentation, macrocytosis, etc., etc. Euthyroid sick syndrome, क्या होता है? The patient is clinically euthyroid, but if you look at the laboratory reports, it looks like hypothyroidism. That's a point you need to appreciate. Now, when does it happen? Whenever there is any systemic illness and the endocrinal milieu will have a adaptive mechanism which is responsible laboratory wise this euthyroid sick state. You are evaluating bleeding in surgical patients. What are the most common reasons for the surgical bleeding? It is the incomplete mechanical hemostasis which is responsible. Drainage sites, tracheostomy wounds, IV infusion sites. It is all that ineffective local hemostasis. Now, with regard to the hemostatic disorders, out of 2, 7, 9, 10, which are vitamin K dependent, 7 on which PT is dependent, it has the shortest half-life. That's the reason whenever vitamin K deficiency occurs, early vitamin K deficiency may only 7 will fall. That is the reason only PT will get prolonged. But in the late part of the vitamin K deficiency, even 2, 10, 9, everything will fall. So both the PT and also APTT become prolonged is what you need to basically remember. Now, doctor, factor 9 deficiency, what is that called? Rosenthal syndrome. And factor 5 is a labile factor. So if you happen to store the blood, then factor 5 deficiency is what you typically see. So what is the most sensitive method for detection of prostate cancer? The digital rectal examination plus PSA is a very fastest way. Primary systemic amyloidosis, what is the cause, doc? Multiple myeloma, Waldenstrom's macroglobulinemia, non-Hodgkin's lymphoma, they're all the various causes of the primary systemic amyloidosis, which is often because of a clonal B-cell disorders. That's what you need to remember. It is amyloid AA protein, which occurs in inflammatory and infectious diseases. There's a rigid abdomen, free air on plain film. Do you want to further evaluate? That itself tells the story that there is a perforation. So there is no point, and it is foolish to waste time on evaluation and investigation. You need to take an action. No further radiological workup is really required. There's an acute onset of epigastric and right upper quadrant pain several hours after a large dinner. So there are similar episodes in the past which resolved after a few hours. And there is a fever, non-bilious vomiting. So what is the possibility? So this is a classical example of cholecystitis, inflammation of the gallbladder. A patient is having abdominal pain. What are the ominous features? If the patient is lying still without moving, if he has hypotension, diaphoresis, they are all the signs that possibility of a perforation and shock. Ternary artery bypass surgery. Some of you are going to be top cardiothoracic surgeons in a short period of time. So now, what are the contraindications for coronary artery bypass surgery? Diffuse disease and heart failure if it is there, or if it is a small vessel. If it is a moribund patient after resuscitation, he is not fit for surgery. So you should know all contraindication for CABG. If any acute MI over 6 hours old, then CABG contraindication. With regard to the aortic regurgitation, when do you want to do the surgery in case of aortic regurgitation? So obviously, aortic regurgitation, the left ventricle is pushing blood into aorta, which is coming back into the ventricle, and at the end of the systole, if you look at the pressure, it is supposed to fall down. But if significant regurgitation is there, it remains high, more than 50. Or end of the systole, because of the regurgitation, the ventricle size did not come down and it is more than 50 mm. Or at the end of the diastole, more than 70 mm. They are all the indications for surgery in case of aortic regurgitation, is what you have to basically remember. Now, with regard to the pancreas, 85% of the pancreatic cancers are all ductal adenocarcinomas. Commonly, they arise in the head of the pancreas. Mucinous cystadenomas are often seen in the perimenopausal women, and they are benign. Basically, see, the cystadenomas are benign. Whereas mucinous cystadenomas, M for M, mucinous cystadenomas can undergo malignant transformation, is what you have to fundamentally remember. Now, duodenum, the very word duodenum ka matlab hai 25 centimeters. Small intestine is 7 meters in length, and inferior pancreatico-duodenal artery is a branch of superior mesenteric artery, one of the favorite MCQ. Now, if you look at the jejunum, its proximal 2/5 is jejunum, and it is wider, thicker, more vascular compared to that of the ileum. And it has got valvulae conniventis that will, jejunum mein valvulae conniventis are there, which differentiates it from the ileum, is what you have to basically remember. And ileum is identified because of the presence of Peyer's patches. Now, jejunal diverticulae, they are very common if there is any connective tissue disorder. 2%, rule of 2 in Meckel's diverticulum. 2% of the population where Meckel's diverticulum exists, and jejunal diverticula need to be treated with end-to-end anastomosis, resect and end-to-end anastomosis. And where are these diverticulae located? They are on the mesenteric side of the bowel, because of the mucosal herniation occurred wherever there is a point of entry of blood vessel, is what you have to basically understand. Whereas Meckel's diverticulum, if you take, it is situated on the anti-mesenteric border. That's what you should remember. Lowest complication rate, ulcerative colitis, where do you have? Procto, that is rectum. Proctocolectomy and ileostomy is considered to have lowest complication rate of it. Now, ulcerative colitis versus Crohn's. Every entrance you go, without a question on inflammatory bowel disease, there is no question paper, doctor. Crohn's is transmural, full thickness of the bowel wall. Granulomas, Crohn's, And colon and rectum. Proctocolectomy cures the patients with ulcerative colitis. Then ulcerative colitis is more a confluent disease in the colon and rectum, whereas Crohn's will keep skipping. It will reach until mouth. Skip until mouth and until anus. Whereas ulcerative colitis is only limited to colon. If you look at ulcerative TB, ulcers are transverse. You can remember, TB is like, you will write TB like this, no? So, ulcers are transverse. Ileocecal area, whenever TB occurs, it is hyperplastic in nature. And the abscess, fistulas, if you look at all of them, they are more often seen in Crohn's disease rather than TB. Familial adenomatous polyposis. With regard to the familial adenomatous polyposis, you should remember is it the long arm or short arm of the chromosome number 5? It is the short arm of the chromosome number 5 on which the familial adenomatous polyposis gene is located, is what you need to remember. So what is Garnet syndrome, Doctor? Epidermoid cyst plus familial adenomatous polyposis is called Garnet syndrome, is what you should remember. So what are the presenting features of left-sided colonic tumors? Is a very important question. How does left side versus right side differ in clinical presentation? Rectal bleeding, abdominal mass, tenesmus. They are all the presenting features of the left-sided tumors. Whereas iron deficiency anemia, abdominal mass, they are the features of right-sided tumors. Then stomas, doctor, ileostomy, colostomy, they are all the favorite topics of the examiner. The ileostomy, if effluent, is usually liquid. And a ileostomy and colostomy is usually in the left iliac fossa. Colostomy effluent, if you take it, is usually solid. And because ileostomy effluent is usually liquid, fluid electrolyte problems are more likely in a ileostomy patient. And the ileostomy is usually sited in the right iliac fossa, whereas the colostomy is usually sited in the left iliac fossa. Now, doc, what are the atypical clinical presentations of the appendicitis? Is one of the favorite questions. Pelvic appendicitis can simply present like a diarrhea. That's why the appendicitis is always a mimicker. It's a great mimicker, is what you need to remember. Any hyperextension of the hip joint will cause abdominal pain if it is retrocecal appendicitis. And a deep tenderness is often present in the loin in case of retrocecal appendicitis. And retrocecal appendicitis, the rigidity, even if you apply deep pressure also, rigidity may be absent. That's the reason in the diagnosis of appendicitis, you need not be dogmatic. Hey, this is not there because 2 + 3 is there. It can be 5. No, it may not be 5. It may be 4, it may be 3, it may be 2. Anything can happen. So we cannot be dogmatic in our clinical observations with regard to our diagnosis in case of appendicitis because it's a great mimicker. Inferior rectal artery is a branch of internal pudendal artery. Superior rectal artery is a continuation of inferior mesenteric artery. Middle rectal artery is from the internal iliac artery. So superior rectal, middle rectal, inferior rectal, they three are from three different vessels. So superior rectal artery is from the inferior mesenteric artery, middle rectal artery is from the internal iliac artery, inferior rectal artery comes from the internal pudendal artery. Favorite MCQ of the examiner. कल एग्जाम में सेम क्वेश्चन आएगा, मुरली भरद्वाज याद आएगा आपको. Now, adventitious bursa is an acquired bursa which is generated from a connective tissue. If there is a mid-clavicular fracture and overriding of the fragments, how do you treat? Figure of 8 bandage is what you need to remember. A 70-year-old shortening of the limb, axial rotation, deformity, tender thickening of the greater trochanter. So it is a peritrochanteric fracture of the femur. In Paget's disease, if you look at the skull, you can see the thickening. Cranial paralysis can occur. Bones are greatly thickened and very vascular. A 9-year-old boy limping, pain in the right knee 2 days after a fall in the street. He was sick. So what are the most probable diagnosis? Acute osteomyelitis of the femur. Carpal tunnel syndrome. You should remember, any wrist fracture can lead to the carpal tunnel. Rheumatoid arthritis can lead to carpal tunnel. Pregnancy is one of the etiological factors for carpal tunnel, is what you should remember. Adolescent female, limited wrist movements, especially dorsiflexion and weakness of the hand, especially grip. There's a radial deviation of the hand with abnormal prominence of the ulna. So what is the most likely diagnosis? This is called Maid-Lungs deformity. The volar and ulnar tilting of the distal radial articular surface, Maid-Lung deformity. So it is a growth disturbance of the volar ulnar distal radial physis. Is what you need to remember. 18-year-old presented because of the knee knock, separation of the medial malleoli by 3 inches when standing. The knees are in contact. What is your diagnosis? This is called genuvalgia. Now, whenever there is any injury of the ankle joint, the joint is unstable if there is any rupture of inferior tibiofibular ligament, is what you need to remember. Spraining of the joint. There is a partial rupture of ligament, usually follows an indirect trauma. There is a swelling, local tenderness of the joint affected. So that is what happens with the spraining of the joint. So doctor, with this, we will call it a day. And at least before we go to sleep, instead of calling off, I thought 50 questions let us discuss. Some amount of inspiration for you to research yourself, you know. Still we are having, how many days, doctor? 12 days of time, 10 days of time, you can say. But 10 is great. You can do a lot of things. At least 10 topics if you improve every day that you have not read. Not sure. 10 into 10, 100 topics, suddenly your score has gone up by 70, 80 marks in the next 10 days. Is it possible? It is possible if you think you are going to do that. So definitely every day you have Dr. Murali Bharadwaz holding your hand, spending time with you to become your classmate every day in your life. Good luck, and I am waiting for a great news that you cracked the top rank in the NEET PG Topper. Good night.